Now moving from diabetes to thyroid disorders, our next speaker is Dr. Dana Hiasat. She graduated from the University of Jordan and has an associate's degree in internal medicine. She is currently a diabetologist and endocrinologist working at the National Center for Diabetes, Endocrinology and Genetics. She will be talking about thyroid disease in pregnancy.
Good evening. Pregnancy has a profound and complex impact on thyroid gland and thyroid function. The thyroid increases in size by 10% in iodine-sufficient countries and by 20 to 40% in iodine-deficient areas. T3 and T4 production increases in pregnancy by 50%, along with 50% increase in daily iodine requirement due to the increase in urinary iodine excretion and increase in T3 and T4 synthesis. Pregnancy also has a significant effect on the immune system. There is partial immunosuppression during pregnancy in order to maintain the fetal-maternal allograft. Clinical improvements usually occur in certain immunological disorders, such as rheumatoid arthritis, Graves' disease, and psoriasis, when they become pregnant. On the other hand, SLE may flare during pregnancy, indicating that there is no overall immunosuppression during pregnancy. Early in pregnancy, increase in estrogen production will lead to increase in thyroxine binding globulin, and this will lead to increase in total T4 concentration and decrease in serum T4, free T4 levels. At the same time, maternal T4 turnover increases in pregnancy due to placenta dehydrogenase, and these two changes may be followed by a rise in TSH to a new equilibrium. This rise in TSH is usually not appreciated by routine thyroid testing. On the other hand, and at the same time, the high circulating beta-SCG will cross-react with TSH receptors, leading to increase in free T4 synthesis or production by the thyroid gland and partial suppression in TSH. So the changes caused by increased thyroxine binding globulin and the high maternal turnover, which will be followed by a rise in TSH, it will be neutralized by the effect of beta-SCG, leading to partial suppression in TSH. So in normal pregnant women, most or the thyroid gland maintains euthyroid with only minimal fluctuations in TSH and T4, while in women with limited thyroid reserved to either to autoimmunity or iodine deficiency, hypothyroidism may develop. How do thyroid function tests change during pregnancy? Studies have shown that serum T4 concentration decreases progressively with the progression of gestation, and the measurements of free T4 using different immunoassays are complicated by the increased concentration of total thyroxine binding globulin and decreased concentration of albumin. And these two changes may cause immunoassays to be unreliable. That's why interpretation of free T4 should be according to the methods used, and because of free T4 reference interval varied widely according to the methods, interpretation of free T4 interval should be both method and trimester specific reference ranges, keeping in mind that such ranges are also influenced by the iodine status of the population studied. Because of unreliability of immunoassays used for T4 measurements and the need to be both method and trimester specific, serum TSH will be a more accurate indication of thyroid status in pregnancy than any other alternative methods. And here is the recommendation by the American Association of Clinical Endocrinologists and the American Thyroid Association, which states that in a pregnancy, the measurement of total T4 in addition to TSH should be done to assess thyroid status. This figure shows the inverse relationship between beta-STG and TSH concentration, with a mirror image between the nadir of TSH and the peak concentration of beta-STG at the end of the first trimester. And as you can see, that the largest decrease in TSH is during the first trimester, and that TSH with its reference ranges increases gradually in the second and third trimester. So TSH and its reference ranges do vary between trimesters. Therefore, trimester-specific reference ranges for TSH should also be applied. And this table shows the median TSH concentration in the 3 trimesters. If trimester-specific reference ranges for TSH is not available, the following reference ranges are recommended. The upper limit of normal TSH in the first trimester is 2.5 milli-international unit per liter, while the upper limit of TSH in the second and third trimester is 3 milli-international unit per liter. So the thyrotropic activity of beta-STG results in a decrease in serum TSH in the first trimester. Therefore, during pregnancy, women have lower serum TSH concentration than before pregnancy, and frequently TSH is below the classical lower limit of 0.4, and in a small percentage of women, TSH may be very suppressed, less than 0.01, yet still represent a normal pregnancy. Since beta-STG concentration are higher in multiple pregnancies than in singleton pregnancy, you are expecting that the downward shift in TSH reference interval to be greater in twin pregnancy than in singleton pregnancy. We come now to hypothyroidism in a pregnancy. Overt hypothyroidism in the first trimester is defined as an elevated TSH more than 2.5 in conjunction with a decreased PG4 concentration, or TSH more or equal to 10, irrespective of their PG4 levels. While subclinical hypothyroidism is defined in the first trimester as a serum TSH between 2.5 and 10 with a normal PG4 concentrations. Overt hypothyroidism occurs in around 0.3 to 0.5% of pregnancies, while subclinical hypothyroidism occur in 2 to 3% of pregnancies and 5 to 15% of women in childbearing age, they have thyroid autoantibodies. Causes of hypothyroidism, of course, Hashimoto thyroiditis accounts for the most common cause of hypothyroidism. Other causes include iodine deficiency, radioactive iodine ablation, or surgery either for hyperthyroidism or malignancy, and congenital hypothyroidism. What adverse outcomes are associated with hypothyroidism during pregnancy? Several obstetrical complications have been encountered in patients with hypothyroidism or with maternal hypothyroidism. And this was made as an attempt to illustrate the relationship between maternal hypothyroidism and pregnancy outcome. Maternal hypothyroidism was defined as overt hypothyroidism with a black circle and subclinical hypothyroidism with the black square. And from this study, you can see that the risk of spontaneous abortion early in a pregnancy is significantly associated with overt hypothyroidism and subclinical hypothyroidism. One study has shown an association between anemia and overt hypothyroidism. Studies by Davis and Lennon also demonstrate an association between overt hypothyroidism, subclinical hypothyroidism, and gestational hypertension. Placental abruption, postpartum hemorrhage, was associated also significantly with overt hypothyroidism and subclinical hypothyroidism. Preterm delivery and or low birth weight, along with fetal distress, they all represent the most repeated association with overt hypothyroidism and subclinical hypothyroidism. Some studies have shown an increased risk of congenital anomalies, including congenital heart disease, and also there is increased risk or frequency of cesarean section with overt hypothyroidism, but not with subclinical hypothyroidism. And as you can see here, that adverse obstetrical outcomes occurs when we are late in diagnosis of hypothyroidism in a pregnancy, or when we replace or when we have inadequate replacement of thyroxine. While adequate replacement of thyroxine is able to reduce the chance or the risk of miscarriages and premature delivery in patients with hypothyroidism. Synthesis of thyroid hormone by the fetal gland, it will not happen before the 12th week of gestation. So before the 12th week of gestation, the maternal supply represents the only sources of thyroid hormone for the fetus. And as you can see here, that the maternal to fetal transfer of thyroid hormone continues all through pregnancy until delivery without interruption. Maternal T4 has been measured in sonomic fluid as early as 4 weeks of gestation. And multiple studies have shown that maternal thyroid hormone play a critical and biological role in many aspects of development of the brain of the babies. And these aspects include neurogenesis, neuronal migration, axonal and dendritic formation, myelination, synaptogenesis, and neurotransmitter regulation. What's important for us to know is that the most important for all these aspects of brain development is the maternal T4 concentration, because local T3 production in the brain depends mainly on maternal or local production of T3 from maternal T4 by dehydrogenase enzyme. So as you can see, the most important is the local production of T3 from maternal T4 by dehydrogenase enzyme. So if we have low concentration of T4, normal maternal concentration of T3 will not protect the fetus or the damage that will happen to the brain or the brain of the baby. Several rodent models also have demonstrated that maternal hypothyroxemia was associated with multiple effects in the cerebral and cerebellar cortex, as well as in auditory and visual development. So we said that maternal thyroid hormone are very important for the neurodevelopment of the babies, and the best example came from a study done by Du et al., which was published in the New England Journal of Medicine in 1999. In this study, they compared the neurodevelopment of 62 children of women who had high TSH or hypothyroidism with 124 children with women who had normal TSH. And they do around 15 tests relating to reading, intelligence, visual, motor activities, and they found by the end of the study that children born to hypothyroid women, they do less well in all tests, and they have an average of 4 points less on the IQ in comparison to children who had to children with women with normal thyroid function, and 15% of children with women with hypothyroidism, they have an IQ of less or equal to 85% in comparison to only 5% of children with mother or with normal TSH. So what we conclude from this study, that hypothyroidism in a pregnancy, even if mild, can determine a reduction of neuropsychological performance in children, and thus screening of hypothyroidism in pregnancy may be warranted. Another study, called the Generation R study, also showed the importance of keeping normal maternal thyroid hormone within normal range, and this study showed that hypothyroxanemia in women will cause delay in expressive language in their children, indicating that hypothyroxanemia during the first weeks of gestation represents the main maternal factor correlated to impairment of neuropsychological development. Conditions that result in early hypothyroxanemia, if it is combined to later thyroid defect, it can result in irreversible brain damage. However, in congenital hypothyroidism, if we could introduce thyroxine postnatally and early, the brain damage could be prevented by early treatment with thyroxine, because normal maternal concentration of thyroxine will prevent the fetal brain from damage until delivery. How should TPO positive euthyroid women be monitored and treated during pregnancy? Studies have shown that in TPO euthyroid women, TSH levels increases progressively as pregnancy progressed, with 20% of women having a supranormal TSH at the time of delivery. So in women with TPO positive or who are TPO positive, both overt hypothyroidism and subclinical hypothyroidism may occur during the stress of pregnancy, as the ability of the thyroid hormone to increase production is compromised, and increasing demand will outstrip the supply, and when this happens, TSH will be elevated and hypothyroidism will happen. So euthyroid pregnant women with positive antibody show impairment of thyroid function during gestation, and they seem to suffer from high rate of obstetrical complications such as miscarriages and premature delivery. And that's why substitution of thyroxine to those patients is able to lower the chance. As you can see here, the substitution of thyroxine is able to lower the chance of both miscarriages and preterm delivery in such women. TPO not only constitute a risk for development of hypothyroidism in pregnancy, but also constitutes a risk factor for perinatal death, postpartum thyroiditis, lower motor and intellectual development in offspring, in addition to increased risk of miscarriages and preterm delivery. Yet, universal screening for the presence of anti-TPO, either before or during pregnancy, is not recommended, and there is insufficient evidence to recommend for or against thyroxine therapy in TPO positive euthyroid women. However, because of the risk of development of hypothyroidism in euthyroid women with positive antibodies, it is reasonable to evaluate TSH elevation approximately every 4 weeks during the first half pregnancy, and also we have to do serial testing for thyroid function in the mid-trimester, and at any time TSH will be more than the trimester specific range, which those women should be treated. Concerning subclinical hypothyroidism, thyroxine treatment was proved to improve the obstetrical outcome in such women, but it has not been proved to modify the long-term neurological development in the offspring. During pregnancy, it is necessary to increase thyroxine dose of about 30 to 50%, and this is due to multiple factors like weight gain, increased plasma distribution volume, increased placenta dehydrogenase activity, and the use of vitamins and other drugs that will lead to poor absorption. In hypothyroid women who are pregnant and treated with thyroxine, it is necessary to monitor thyroid function every 4 weeks during the first half pregnancy, at least once between 26 and 32 weeks of gestation, 2 weeks after each adjustment, and of course 6 weeks after delivery, with a return of thyroxine dose to pre-pregnancy dose after delivery. Is universal screening for thyroid disease recommended in pregnancy? Universal screening of healthy women for thyroid dysfunction before pregnancy is not recommended. However, healthcare givers should identify patients who are at high risk for thyroid illness, such as women above the age of 30, we have history of thyroid dysfunction or surgery, history of goiter, TPO positive, history of miscarriages, preterm delivery, or infertility, or if we have a history of neck radiation or morbidity of this woman. Now we'll come to hyperthyroidism and pregnancy. The prevalence of hyperthyroidism in pregnancy ranges from 0.1 to 0.4, with the Graves' disease accounting for more than 85% of cases. And we all know that Graves' disease occurs due to the presence of TSH receptor antibodies, which is present in over 95% of patients with active Graves' disease. And it's very important to differentiate in patients with hyperthyroidism between Graves' disease or hyperthyroidism and hyperemesis gravidarum. Hyperemesis gravidarum is reported to occur in 0.3 to 1% of pregnancy, and is defined as persistent of nausea and vomiting in the first trimester, resulting in greater than 5% reduction in weight, with some patients will have ketonuria, dehydration, liver and electrolyte imbalance in severe cases. And the onset of nausea will start after 4 weeks of gestation, with worsening between 7 to 8 weeks of gestation, and most women will recover by the end of the first trimester. However, 60% of cases will got complete recovery by 20 weeks of gestation. So to differentiate, this is a typical case of hyperemesis gravidarum, 32-year-old woman, 10 weeks pregnant, presented with nausea, vomiting, and 2.5 kilos weight reduction. And on examination, she is a bit dehydrated, euthyroid without a goiter, and has normal eyes, with suppressed TSH and high free T4 level. So to differentiate between hyperemesis gravidarum and thyrotoxicosis or Graves' disease in pregnancy, the diagnosis of hyperemesis gravidarum will depend on the presence of symptoms such as nausea, vomiting, dehydration, lack of symptoms before pregnancy, absence of goiter and eye manifestations, and of course, patients with hyperemesis gravidarum will have or the antibodies, TSH receptor antibodies, will be negative in such patients. Hyperemesis gravidarum is a reversible condition and rarely requires antithyroid medication. And we can measure TSH receptor or what we call TRAB antibodies to distinguish between hyperemesis gravidarum and Graves' disease. What complications are associated with thyrotoxicosis due to Graves' disease? With Graves' disease or thyrotoxicosis in pregnancy, we will have the following complication. We could have spontaneous abortion, congestive heart failure to the mother, thyroid storm, preeclampsia, premature delivery, low birth weight, and stillbirth. And of course, if we could control thyrotoxicosis all through pregnancy, we can achieve better reduction in low birth weight, in prematurity, and in severe preeclampsia in comparison to those who had uncontrolled thyrotoxicosis during pregnancy. What about infants? We said that we have a lot of maternal complications related to Graves' disease or thyrotoxicosis during pregnancy. What about infants or babies? Babies who are born to thyrotoxic mothers, they could have both central congenital hypothyroidism, and central congenital hypothyroidism in such infants or babies could be due to two conditions. The high maternal concentration of T4 will pass the placenta and causing suppression to the fetal thyroid gland, and at the same time, the excessive use of antithyroid medication could again pass the placenta, causing blocking to the fetal thyroid gland, and these two causes can cause central congenital hypothyroidism in the infants or babies. However, 5% of neonates of mothers with Graves' disease, they can have hyperthyroidism rather than congenital hypothyroidism, and again, this is due to transplacental passage of maternal TSH receptor, or what we call TRAP, and fetus who had neonates with hyperthyroidism or fetuses with hyperthyroidism can have intrauterine growth retardation, fetal tachycardia, fetal goiter, advancement in bone age, fetal hydrops, and we could have also preterm delivery and fetal death in such infants or neonates. What's important to us to remember that even if the patients before pregnancy was treated with radioactive iodine, still we could have very high titer of TSH antibodies which may remain still elevated following radioactive iodine, and it can pass through the placenta, causing hyperfetal or neonatal thyrotoxicosis or hyperthyroidism. That's why termination of serum TSH receptor or TRAF by 24 to 28 weeks of gestation will be helpful in detecting pregnancy or fetuses that are at high risk to develop thyrotoxicosis. And at any time, a value over 3 times the upper limit of normal is an indication for close follow-up of the fetus. What are the indications for ordering TSH receptor or TRAP during pregnancy? Any mother with active hyperthyroidism, we have to order TRAP. Previous history of infant or delivery of infant with hyperthyroidism or thyrotoxicosis is also an indication for ordering TRAP, and as I said, previous history of treatment with radioactive iodine, because still we have very high titers with TRAP that could pass the placenta. Of course, pre-pregnancy counseling in patients with hyperthyroidism is very important, and using contraception is very important during active disease, and also we have to achieve euthyroidism before conception. PTU, now we come to the treatment of hyperthyroidism. PTU, or what we call propylthiouracil, is preferred for treatment of hyperthyroidism in the first trimester. And propylthiouracil, or the use of propylthiouracil, is only indicated for treatment of hyperthyroidism in the first trimester. And after first trimester, we have to stop using propylthiouracil because of the risk of hepatic toxicity. What's important for us to know that combination of antithyroid medications and thyroxine in a phenomenon called block and replace should be avoided in pregnancy, and the cause for that is that combination of antithyroid drugs and thyroxine will cause the placenta to be highly selective, or the transplacental passage of antithyroid drugs will be high, but for thyroxine it will be negligible. So the addition of thyroxine to antithyroid medication will not protect the fetus from antithyroid drug-induced hypothyroidism. Of course, frequent monitoring for T4 and TSH should be done during pregnancy, and we have to use the lowest dose of antithyroid medication. As I said, the proper therapy in the first trimester, then we have to shift to neomarbitol or carbimazole for the second and third pregnancy. And we have also to remember that we have to maintain maternal total T4 level in the upper 1/3 of normal in order to avoid hypothyroidism in the fetus. We have to monitor total T4 in 2 to 4 weeks, and we have to change antithyroid drugs as needed. And if the mother suffered from thyroid toxicity measurement of TRAB or TSH antibodies between 22 to 28, it's very important to assess the risk of fetal hyperthyroidism. Beta blocker are commonly used in pregnancy. Some studies reported increase in first trimester miscarriages with the use of beta blocker, and some studies talk about that beta blocker can cause intrauterine growth retardation and neonatal hypoglycemia. Iodine is avoided because of risk of neonatal hypothyroidism and pregnancy. Now, we come to what we call it postpartum thyroiditis. Postpartum thyroiditis is defined as the appearance of thyroid dysfunction in the first postpartum year in women who are euthyroid prior to pregnancy. Most studies reported a significant association between postpartum thyroiditis and depression, and in a recently published article, this article reported that 50% of women will remain hypothyroid at the end of the first postpartum year. So we are talking about 50% chance of permanent hypothyroidism in patients with postpartum thyroiditis. Now, the prevalence of postpartum thyroiditis is around 80% with wide variation between countries. Some countries they have a prevalence rate of 1%, while others they have a prevalence rate such as the United Kingdom of around 17%. The classical form of presentation. The classical form of presentation of postpartum thyroiditis is transient thyroid toxicosis followed by hypothyroidism, then return to euthyroid state. However, 32% of patients may present with isolated thyroid toxicosis, and 43% of them will present with isolated hypothyroidism. And as I said, that most patients by the end of the first year, they will return euthyroid. Patients who presented with isolated thyroid toxicosis, the presentation is usually asymptomatic or mild, while most patients who present in the hypothyroid phase will be symptomatic. Women with one episode of postpartum thyroiditis, they have a 70% chance of recurrence with next pregnancy. Also, patients with TPO positive during pregnancy, they have a very high risk to develop postpartum thyroiditis. Selenium as an antioxidant is reported to reduce the risk of postpartum thyroiditis, but there's a lot of reports of increase in the development of type 2 diabetes with the use of selenium. And of course, as I said, when women have TPO, we have to do close monitoring for TSH and T4 every 3 to 6 months because of the high risk to develop postpartum thyroiditis. If the patient is symptomatic during the thyrotoxic phase, we have to use beta blocker, keeping in mind that antithyroid drugs are not recommended for treatment of postpartum thyroiditis or for the treatment of thyrotoxic phase of postpartum thyroiditis because it is a type of destructive thyroiditis. And in case of hypothyroidism, thyroxine should be initiated with always future possibility of future discontinuation of thyroxine, and we have to take the thyroxine treatment after 6 to 12 months from initiation of thyroxine treatment, keeping in mind that tapering of thyroxine treatment should be avoided in women who are actively attempting pregnancy or pregnant ladies. So, in conclusion, profound physiological changes of thyroid function occur in pregnancy. Differentiation between hyperemesis gravidarum and Graves' disease may be difficult but essential. Propylthyroxine is the drug of choice in treating hyperthyroidism in the first trimester. Then we have to shift it to methimazole in the second and third trimester, and we always should watch for neonatal Graves' disease in a woman with a history of treated Graves' disease. And finally, postpartum thyroiditis is common and often an overlooked problem postpartum.
Thank you very much.
Excuse me, Doctor. Thank you.
Thank you.
There's a space. No other.
دكتور جهاد حداد. دكتورة دانا حياصان.
Smile.